And now I'm going to talk to Dr. Cerna. Dr. Cerna is a local radiologist who read my mammogram. Let's put the video on to hear what he has to say about mammogram.
So here we have Dr. Cerna, radiologist, who's going to be looking at my mammogram, which I just did. Dr. Cerna, a lot of patients are hesitant to get their mammogram done. Why do you think this is so?
Well, I think part of the problem is the culture. Unfortunately, here in South Texas, many Hispanic women, including my mother, are very apprehensive about getting any type of studies, whether it's a mammogram or a pelvic exam. But it's very important down here that we do so. We have a very high incidence of breast cancer and also cervical cancer, so it's extremely important that you get those studies done as directed by your doctor.
What amount of radiation the woman is exposed to during the mammogram?
With the, that's a very good question, and that's always a big concern. But with the amount of radiation exposure, it's based on the type of equipment that you're that you're having the studies performed with. Here at DHR, we have state-of-the-art equipment, and we have mammography units that automatically regulate the amount of radiation and exposure to the patient. And studies have shown that the amount of radiation is similar to taking a flight, let's say from here to Houston.
Very good, very good. So that's there, that image is my study. Am I right?
Yes, this is your mammogram that was performed today. And luckily we have a prior mammogram that was done back in 2012. So it's extremely important and helpful for the radiologist and for the doctors to have a prior study to compare, because we're looking at changes from one year to the next. So here we have a study back in 2012, and we'll be able to compare it to 2017, and we're looking for any subtle changes that the mammogram will pick up.
Right. Changes like what?
We're looking for new masses, which would show up as a bright spot on the mammogram, and we do not see that on your mammogram.
Excellent.
We're also looking for subtle, small microcalcifications, which we can pick up by the mammogram. Here's an example of a very small microcalcification, benign appearing, not worrisome, but these are the type of calcifications that we're looking for. So we're looking for calcifications, we're looking for any type of masses, we're looking for skin thickening, we're looking for changes in the nipple area, such as nipple retraction, we're looking for any type of lymph nodes up in the axilla.
You know, a lot of time patients are told there's a calcification, they get very worried. Should we be worried when we're told there is a microcalcification?
Not necessarily. Microcalcifications, unfortunately, are just part of every mammogram, or most mammograms that we see, and it's just a part of aging, if you will. It's the type and description of the microcalcification that's concerning. So you can have a spectrum of benign appearing microcalcifications, which are normal. It's the more clustered microcalcifications that become a little bit more suspicious, and that will direct us to do further testing.
When do you send the patient for sonogram? A lot of time we're asked to send the patient for a breast sonogram. When do we do that?
The sonogram is a very helpful tool for breast imaging. It allows us to actually look at the soft tissues of the breast in real time. So when a patient comes in with a complaint, let's say breast pain, we'll get a diagnostic mammogram and also an ultrasound. The mammogram is essentially going to tell us whether or not there's a mass there, but the ultrasound will tell us what type of a mass. Is it solid? Is it cystic? Is it irregular? Is it benign appearing? Also in younger patients below the age of 40, if they come in with breast pain or any type of complaints, usually we want to do an ultrasound first before we expose the patient to any kind of radiation.
Very good. What if a woman has had breast reduction or implant? Do you recommend mammography or an MRI?
If a patient comes in with those type of surgeries, if they're not having any type of specific complaints, and just a regular routine mammogram, whether they've had a reduction or augmentation with implants, we would first do a mammogram. Of course, we would first do a mammogram, and then based on that, if there's any changes or anything concerning, then we might consider an MRI. Now, if a patient comes in and says they think they might have a rupture of an implant, then we'll go directly to MRI.
Very good. Dr. Cerna, is there anything else you want to tell the ladies so they can come in this month and get their mammograms done?
Yes, absolutely. So here at DHR, well, at any hospital here in South Texas, it's October, and this is breast imaging month. So we encourage you. I'm begging for you to please come on down and get your mammograms done. Not only DHR, but other hospitals are offering savings to get your mammograms to try to come in. But most importantly, we need to follow your doctor's recommendations. We need to do your yearly mammograms. We need to do your screenings, your diagnostics. It's very important that we do not waste any time because you're fearful of getting that study done. You'll come in, we'll take care of you, and we'll make sure that you get well taken care of.
Thank you so much, Dr. Serna.
Thank you so much, Dr. Serna, for your contribution to the mammogram.